Hi, I'm Dr. Charles Jordan, an orthopedic surgeon in Miami, Florida. And today we're going to be talking briefly about an interesting case of a very active elderly lady with an unstable ankle fracture. She is 71 years old and very active, lives alone with her husband, and they actually go out every day and walk for several blocks in the park. Unfortunately, however, she is a relatively poorly controlled diabetic and has significant peripheral artery disease and atherosclerosis. As you can see on the x-rays, this is a lady with a unstable bimalleolar ankle fracture. She presented to the emergency department after having fallen off of the side of a curb while she was doing some grocery shopping. You can see of note, especially on the lateral view, the significant atherosclerosis that she has, and the vessels that you can see are very significantly calcified. She has a history of several wounds in the past. She hasn't gotten to the point where she really has diabetic ulcers and to that extent, but she has a very poor soft tissue envelope. She's active and healthy, and this is certainly the type of fracture that one would generally elect to treat with surgical intervention and stabilize her fracture. So when she initially presented to the emergency department, as you would expect, she had a gross deformity and significant amount of swelling. We performed a closed reduction and placed her in a splint and decided on staged intervention and waited until her swelling went down. But given her significant risk of wound complications and skin compromise, this was a case that I would consider being a very challenging one with even standard open reduction and internal fixation. So we waited for the swelling to go down, and several days later brought her back for an open reduction and internal fixation. But given the fact that she was such a poor candidate for open incisions, we actually decided to use the FibuLock. This was a fracture pattern that was very amenable to this type of fixation. The FibuLock has several options for distal fixation, and even in a fracture such as this, where the fibular fracture was quite distal, we were able to get a very appropriate fixation distally. The reason why I chose to use FibuLock was because it allowed me to achieve a very appropriate fixation both proximally and distally while maintaining a minimally invasive approach and leaving the soft tissue envelope completely undisturbed. The proximal talons allow for proximal fixation and to control rotation, while distally there's several options for distal screw placement, which allow us for a lot of variability and a lot of options in any fracture pattern. We followed a standard postoperative protocol, and she was in a splint postoperatively for 2 weeks. We were very comfortable with her soft tissues and were able to take her stitches out at that point and placed her in a cam walker boot for another 4 weeks. She remained non-weight bearing for a total of 6 weeks and was quickly able to regain her range of motion and her strength through therapy during the period that she was non-weight bearing, and was able to resume ambulating very quickly. Thank you very much.